So let's proceed with our lecture. Okay, so first we have to have a historical understanding of how the patient-physician relationship was set up. Originally, the patient will go see the physician will give the patient the services or the goods, for instance, medications, and then the patient basically pays for the services or the medication that was given to them by the physician. And when pharmacology was not yet a profession and it wasn't an established science, physicians themselves made their own medications that they gave to their own patients. They have the mortar and pestle with them and then basically mixed it with water and gave it to the patient to take. And also we have to understand that during that time, those who can't afford it basically ask physicians to come to their homes and get seen by the physician. And we've talked about this in chapter 3 about the history of medical education. Everything that the doctor needed could fit in a satchel, so they would just bring it over to the patient's home, treat their patients there. These are also the rich people who can afford physicians. So a lot of people would actually go to almshouses or poorhouses that were the precursors of the hospitals. And nobody went there if you had money because you basically end up getting sicker. So what we need to remember about this arrangement is that there are two parties here, the patient and the physician. So the first party is the patient because the patient is the one receiving the care. The physician, who is the provider of care, is then the second party. So the patient-physician relationship can then be considered a two-party relationship. What we have now, though, in the current arrangement is that this relationship has evolved with a third party involved, and we call that the third-party payer source. All right, let's examine this slide. If you look at the green arrows, those are the payments, and the blue arrow is for services. So this is us, first party, and then this is the provider of care, either a physician, an institution, a clinic, or a hospital that provides the care. So that's the blue arrow. Now, rather than the patient directly paying the provider of care, we now have a third-party payer that's involved, and that third-party payer, which is the insurance companies, are the ones responsible for paying the providers of care. Now, the third-party payer source, of course, doesn't do this out of the goodness of their hearts. There has to be some money involved where it comes from, wherein they are able to put together those resources so that they're able to afford to pay the providers of care. And that would be the employer of the patient, who pays part of the premiums for the health insurance, or the government that would pay, say, the premiums for Medicaid or for other government programs like TRICARE if you're with the military. Okay? Now, the patient also contributes to the premium in the case of employees. That's why there's also a green arrow here, because the patient contributes to the monthly premium, which is taken out of his or her paycheck, and it goes straight to the third-party payer source, which is the insurance company. Let's look at the national healthcare expenditures in 3 time periods. Up here is when the Affordable Care Act, or Obamacare, was enacted. So the total cost of care, healthcare expenditure, was 2.6 trillion US dollars. It was close to 18%, 17.6% of our gross domestic product. And the cost was around $8,500 $8,400 per person. Now, we have explained all these terminologies in Chapter 1, so you already understood what this stands for, GDP. 5 years later, it has increased to 3.2 trillion in 2015, about 17.8% of the gross domestic product, still close to about 18%, and it has gone up to almost 10,000 per person. A year later, in 2016, it has gone up to 3.3 trillion US dollars. That's the total expenditure. It's still at 17.8% of gross domestic product. Now, this is very important because if it did not go up between these 2 years, that means it could be a sign that healthcare expenditures is stabilizing. However, the cost per person has actually increased again, which is now in 2016 is pegged at $10,348 per person. One thing we know is that healthcare expenditure is continuously rising, but it did experience a slowdown between the years of 2004 and 2005. And it's the slowest growth in spending since 1999. And studies have shown that this may all be attributed to the controls set up by managed care, which would be the likes of prospective payment or prospective reimbursement methods, and the prospective reimbursements for hospital stays, and also restrictions on physician fees. So we'll learn about capitated fees in a few, but a lot of this has been attributed to controls put in place by managed care. Now, there are also studies that show that this growth, this slowing of the growth of healthcare expenditure may have been attributed to the economic downturn of late 2008, because when people don't have that much money, they wouldn't be spending much for healthcare. A lot of people also lost access to care because they lost their jobs, which meant they also lost their healthcare coverage. So let's compare national health expenditures and how they are distributed, comparing two time periods. So here, it's in 2010. So take a look at the biggest chunks of spending we did. 31.4% for hospitalization and almost 19% for physician services. Also, in 2010, when added together, hospitalizations and payment for physicians and clinical services comprise a little bit more than half of the total expenditures for healthcare in the United States. So this is about 51% of the total expenditures went to either hospitalization or payments to physicians. So let's compare it to distribution of health expenditures in 2016. So hospitalization slightly increased by a few percentage. So it was 31 and change percent in 2010, and it is now up to 32%. And the expenditure went up from 814 billion in 2010, and it is now 1.1 trillion dollars. What's really interesting, though, is that physician services are still of the same percentage, and it's about 19.9 or 20% of total healthcare expenditures. So it was $515.5 billion in 2010, and it went up to $665 billion in 2016. Nonetheless, though, it's still about 20%. But if you look at this, it still constitutes just about a little half of the total expenditures for healthcare in the United States. It's from 51% combined, both combined in 2010. It's now about 52% in 2016. So these are the areas that actually need to be looked at in terms of increasing costs of healthcare. Now let's look at where the money comes from. So the two previous slides basically told us where the money goes to. Where do we spend the money for? And we said that slightly over half, actually, of the national health expenditure goes to hospitalizations and physician services. Now, this slide here tells us where the money comes from. And there's one important thing I actually want you to look at here. And this is between 1960 and all this following years. By the way, this is 2010 and leading up to the implementation of the Affordable Care Act, otherwise known as Obamacare. But before 1970, basically pre-1965, there was no Medicare or Medicaid, so there's none here. But in 1970, we start seeing that, and it has steadily increased in terms of percentage of where the money comes from. And take a look at Medicare, for instance, which is the gray area of the bar, and it's steadily increasing, which tells us that we have a steadily increasing Medicare population, which means we have more and more people growing older that are living longer. So still looking at where the money comes from, where the source of funds come from, for 2016, we could see that 1/3 of all the expenditures for healthcare was paid for by private health insurance, and it amounts to about $1.1 trillion. That's 34% of the expenditures coming from private health insurance. So the second and third biggest payer sources are Medicare and Medicaid. And, it's 20% for Medicare at $672.1 billion and 17% for Medicaid at $565.5 billion. So all these three taken all together comprise the biggest chunk of where the money comes from, where the financing for healthcare services come from in the United States. And that totals to, let's see, about 71%. So all these three taken together, 71% of the sources of financing come from private health insurance, Medicare, and Medicaid. So at this point, let's try to understand some concepts of insurance. And this is very important because healthcare financing uses these mechanisms involved in terms of insurance coverage. And payment is predicated by having health insurance in this country. And how does insurance work? There's actually a very good video that you will watch after this lecture video that would give you a generic explanation of how insurance works. Now, health insurance is just another form of insurance in general. So insurance works through this concept. This is the main concept that keeps insurance operating. So risk pooling basically spreads the financial risk evenly among a large group of people that pay into the pool. So if we are members of a pool and we're paying health insurance, we actually pay money into it. So what happens is that since all of us are paying money into that pot, it's then evenly distributed to everyone. However, you want it to be evenly distributed, and we will talk about the proper balance in terms of the type of people you want in your pool. Obviously, you want more people who would use less of the money, and you would want more people that would not use money from the pot, and you want less people that would be using money from the pot. That is if you are an insurance company. So Healthcare is very costly for people. So there are certain things that you buy insurance for, such as for your car, and in this country, health insurance. And if we all pool our risks as a group, insurance companies therefore are able to sort of predict and spread out the risk in the entire group. So what happens is that if you have health insurance, it's one way to protect you from an unexpected financial impact of getting hospitalized, for instance. But the good thing about health insurance is that it also covers for routine care. For cars, for instance, if you own a car, your insurance is typically meant for adverse events, such as an accident. Maintaining your car, bringing it for maintenance, is not covered by health insurance, is not covered by your car insurance. But in health insurance, health maintenance visits are covered by it. And it's very advantageous for everyone to have a third-party payer source or health insurance because it decreases the risks of people not seeking care. And the problem with delaying care is that the care gets worse, and therefore the cost of care over a period of time becomes more expensive. So there are several entities that provide health insurance. They could be for-profit companies, non-profit, and also government-sponsored programs such as Medicare and Medicaid, and the State Child Health Insurance Plan, for instance. Also TRICARE for the military and VA. So let's learn a little bit about the history of health insurance. Private health insurance is also known as voluntary health insurance, meaning you have to voluntarily ask for it. Now, until 2018, health insurance was actually not voluntary. It was mandated. Up to some point, there are some exceptions through the Affordable Care Act. We will learn more about this when we talked about health policy, but health insurance is back to being voluntary, meaning if you don't want to have health insurance, you don't have to get it. Whereas with Obamacare, you were required to with the individual mandate. Now, aside from having private health insurance companies, there's also programs that are publicly financed by taxes, and this is Medicare and Medicaid, and they were meant to meet specific needs of specific subgroups of population. So Medicare for the elderly and those that have certain disabilities, and Medicaid for the poor. So the concept of health insurance originated from the concept of workers' compensation. And this was a very broad coverage because it's not only for health insurance, it also covered like wages lost because of injuries or you got sick, which is basically health insurance, but it also paid for death benefits for survivors. So workers' comp basically has the first elements of health insurance because what happened here is that the union or the guild from which the worker belongs to collects a certain amount of money for every paycheck. It then goes into a pot, and whenever any members of the union would require cash assistance or assistance to pay for medical bills and bills for doctor's visits or hospitalizations or even death, and it would also pay benefits to the surviving members of the family of the healthcare worker. But in the 1900s, medical treatments became, because of the medical technology, became more advanced, and with technology we know comes cost. And this just didn't prove to be enough to be able to have a more stable way of predicting the cost of healthcare for every individual. But health insurance basically started with workers' compensation because the concepts are pretty much the same. The first formal type of health insurance was the hospital health plan. There's a video after this particular lecture video, part 1A. that will give you a brief background of how Blue Cross got started. But it all got started with this guy named Justin Kimball. And he basically convinced the University Hospital in Dallas, Texas, to provide care to his group of teachers whom he had asked to contribute a certain amount of money of their paycheck. Every paycheck, they would put it in a pot, in an account, and that amount of money will then be given to Baylor University Hospital, and on the condition that if any one of them was a member of that group of teachers need hospital care, that everything will be paid for. And it became the model for Blue Cross plans around the country. And the American Hospital Association saw the wisdom behind it because it basically gave them a set amount of income. No longer are they looking at this two-party relationship. Patient comes in, pays the hospital gives care, and then patient pays the hospital. And that was then the formalization of a third-party payer group for hospital care. And like I said, the American Hospital Association took this up and they coordinated them into what we now call the Blue Cross network. Now, the other half of Blue Cross, which is Blue Shield, didn't come into being until about 10 years later. And it was the first physician plan, and it gave birth to Blue Shield. So in 1939, the California Medical Association, which is the state branch of the American Medical Association in California, started the first Blue Shield plan, and it was designed to pay physician fees, which is therefore, by default, meant to pay for outpatient visits. So Blue Cross was intended for inpatient stay, while Blue Shield was intended for outpatient healthcare services. So by 1974, Blue Cross and Blue Shield merged. And today they are a joint corporation and they are almost in every state. Some are still not profit, some are for-profit or operated like commercial insurance, but they are considered to be a distinct entity on their own apart from the other health insurance companies. And as history would have it, after the establishment of Blue Cross and Blue Shield, private health insurance took hold in the United States. And it came in the form of employer-based health insurance. During World War II, employees basically accepted health insurance as part of their salary. So they were okay not to get a raise, but the health insurance benefit covers for that. But things have changed since then. That at first in 1948, the Supreme Court said that employee benefits, which include health insurance, will now be part of a union management negotiation. So when unions negotiate for a contract, it'll be part of the bargaining chip. And in 1954, this is where it all started, where we now do not consider health insurance as part of our salary because they are now non-taxable. So whatever contribution you have towards your healthcare premium is supposed to be non-taxable. When it was still considered as part of your salary, it was taxable. But in 1954, that changed. So this was equivalent to getting more salary without having to pay taxes for that. Because if you consider healthcare coverage as part of your salary, you're supposed to pay taxes for those. But in 1954, Congress basically said, no, any contributions made towards healthcare coverage should not be technically salary, and therefore it became pre-tax or non-taxable.